So, new treatments for first-line and virally suppressed people. Here are my disclosures. Where are we now? So we see a pill on the left and an injection on the right. What about the recommended first-line treatments for this year? So what we see here for first-line treatment is pills. And we see we're looking at predominantly integrase inhibitor-based treatment, regardless of where you are in the world. We're looking at dolutegravir, bictegravir, predominantly with TAF-FTC or TDF-FTC, and in some cases, abacavir 3-TC. And this is across the world. But 2021, where are we now? So let's think about injections. The FDA has approved the first extended release injectable drug regimen for adults living with HIV, and that is, of course, cabotegravir rilpivirine. This has also been approved by the European Medicines Agency as Vocabria. So we actually have approved, regulator-approved injectable treatment. So what about the latest data? So if we think about this, the FLAIR Week 96 data reported at CROI last year and is now published in The Lancet this year. And to remind you, the FLAIR study is the treatment naive study, where after 20 weeks, people were switched either to injectable cabotegravir or to continue their oral comparator. So what you see here at week 96 is that there was non-inferiority between the injectable cabotegravir LA, rilpivirine LA, versus dolutegravir abacavir 3-TC. And you can see in the red at the bottom is that there were no new confirmed virological failures between week 48 and 96 in the injectable arm, and therefore no new resistance. And that's a really important point, given that there was resistance in year one. What about the Atlas 2M study? So now we are thinking about injectable cabotegravir or rilpivirine, either given monthly or every 2 months. So the Atlas 2M is long-acting treatment for people that are virologically suppressed. So this is a randomized multi-center study, taking a lot of people, 1,000 people, and randomizing them either to receive the injection every 2 months or every month. And the key primary endpoint was viral load greater than 50 because it's a switch study. And if we look at the virological responses, we can see in terms of success, 91% versus 90, and you can see that non-inferiority was achieved. Now at the bottom, what you see is in terms of confirmed virological failures, there were 2 in the Q4 arm, in the monthly arm, versus 9 in the 8 weekly arm, and 1 additional case between week 48 and week 96. And you can see also that in terms of resistance mutations, you do tend to fail with resistance to rilpivirine, and also in most cases with integrase inhibitor resistance. And that is a concern for the injectable regimen. In terms of safety and tolerability, if you look at the box in red, when we really want to think about the key indicator in terms of tolerability are really adverse events leading to withdrawal. And we can see here there were very small numbers of adverse events leading to withdrawal in this trial. And if we look at on the right, the withdrawals related to injections, we can see that again, very small numbers, 7 or 11 out of 1,000 people is very small numbers of people who find the injection to be problematic. So this is very strong data for week 96 for the Atlas 2M study. And I think the take-home points for this virologically suppressed maintenance strategy is that both regimens, either 4-weekly or 8-weekly, maintained high levels of virological suppression, demonstrated non-inferiority with low overall rates of virological failures and only 1 in the second year of therapy. So it was very well tolerated in both arms with no new safety signals. And the majority of the injection site reactions were grade 1 and 2 and decreased in frequency over time. So subsequent to that, there was also a presentation, which in fact I presented at HIV Glasgow, on the oral lead-in. And do we actually need the oral lead-in? So what happened is in the FLAIR study, the comparator arm, the oral comparator arm, were given the option of getting the injection. And they were given the option of getting the injection there, and their physicians got to decide if they had the oral lead-in and then got the injection, or if they had a direct to inject. So they just got the injection immediately without an oral lead-in. And what you can see in this particular study is that the outcomes were excellent. The direct to inject, so no oral lead-in, 99% virological suppression. So very, very good outcomes. And only one participant met the definition for confirmed virological withdrawal. And if you look at the pharmacokinetics, the drug levels for those who had the oral lead-in versus the DTI without the oral lead-in, you can see excellent drug levels. So safe levels regardless of the oral lead-in, and no safety concerns. So as a result of this, not only has this been licensed by regulators, but the injection cabotegravir-rilpivirine is now in the DHHS guidelines as an optimization strategy for people with HIV on oral treatment with documented suppression for at least 3 months, with no baseline resistance to either medication, no prior virological failure, don't have hepatitis B, are not pregnant or wishing to conceive, and aren't receiving medications with relevant drug-drug interactions. Additionally, they go on to say that switching to long-acting treatment can be advantageous for people for a variety of reasons, including reducing pill fatigue, disclosure concerns or around stigma from taking oral treatment, and to improve quality of life. So I've shown you that data. How will the additional gaps for cabotegravir-rilpivirine be addressed? We still are looking for the data in adolescents and children. We want to know, will this work for people who take treatment badly, who are poor adherers? And there is a study, an ACTG study called the Latitude study currently enrolling to look at those people. But the design of the study means that they want to get their viral loads suppressed first for 24 weeks and then randomize them to the injection or to continue oral treatment. But they're having trouble actually incentivizing people to stay on the treatment for 24 weeks. So the study is enrolling very slowly. They're also looking at an injection into the thigh, whether that could be an alternative to the buttocks, and they're looking for alternative partners to rilpivirine for cabotegravir, such as neutralizing antibodies. Looking on resistance is going on every single study. Collecting ongoing pregnancy data is happening via the PrEP program, as is data around transgender women. There are also implementation studies happening. The Carousel study in Europe is fully enrolled, and LMIC rollout is being considered. So I guess the question I'd want to ask you is, who needs novel compounds? Why do we need these new treatments for first-line and suppressed people? Well, we need them for people in whom there are no more options, so heavily treatment experienced people, and I'm going to talk you a little bit about what drugs are coming for heavily treatment experienced people. People with multi-morbidity or drug-drug interactions, people who say, no more tablets, doctor, I can't swallow, I can't adhere to or tolerate treatment. And then there's the people who are always left behind, and there's no data to support use in these groups. And I think these people also need novel compounds. So the new drug pipeline, if you look at it, what you see is that there are drugs at almost every possible conceptual point in the HIV viral life cycle. And that's amazing in the replication cycle of this virus. Drugs at almost every point. But you also note that there are long-acting drugs at almost every single point. And I think what this really says is that treatment is moving towards long-acting treatment. And that's why in this talk, I'm going to focus on compounds that have long-acting potential. There are a lot of technologies for drug delivery, things like microneedle drug patches, subdermal implants, vaginal rings, pumps, and even oral nanomedicine, which may be a full circle that comes around. And currently, as I've said, we have the long-acting injection already licensed, but there are all of these other technologies which could be harnessed. One of the very promising molecules I want to talk about is islatravir. It's formerly 8591, and it's a first-in-class nucleoside transcription translocation inhibitor, NRTTI, with multiple mechanisms of action. It has very high potency and a high barrier to resistance, and is active at picomolar concentration, so it's very small, and that means it's very easy to combine with other drugs. It's currently in development as a 2-drug regimen together with doravirine, as a once-weekly tablet in combination with MK8507, as a monthly oral for PrEP, and potentially as an implant for PrEP. There's quite an extensive development program from MSD looking at the drug with heavily treatment experienced people, virologically suppressed people, virologically suppressed against BF-TAF, because the original Doravirin studies didn't compare against an integrase inhibitor, so it's important that these do. Treatment naive study against BF-TAF, and again, a switch study for adolescents. And as I've said to you, that islatravir has weekly potential, and there is another drug, an NNRTI, also being developed by MSD called MK8507. And it's already been discussed in a phase 1 proof of concept study. And you can see here that you get a virological decline following a single dose of MK8507. So it's moving forward into development together with islatravir. The other very important drug to talk about is lenacapavir. And this is GS6207 formerly, and it's the first in class selective HIV-1 capsid protein inhibitor with oral and subcutaneous long-acting formulations in development. And it's actually also going to be developed as a once weekly tablet and also as a subcutaneous medication. So this, what I'm showing you on this slide here is simply the point that the pharmacokinetics support 6 monthly dosing. So if you look at the bottom, you can see at the number of weeks before it crosses the IQ greater than 6 line in terms of the drug dose that we want, you can see that it takes 6 months before it crosses that line. So we are looking at a very long half-life. So the next couple of slides are very exciting slides. These were a study that was presented at CROI this year, phase 2/3 study called Capella. And this is looking at this drug for the first time in highly treatment experienced people. So what they took people that were failing on the current regimen with documented at least 2 class resistance, but generally 3 to 4 class resistance, less than 2 active drugs. And they had a randomized cohort which randomized people to receive 10 days of lenacapavir plus their failing regimen. And the alternative was the placebo plus failing regimen. And what the primary endpoint was to see if you could get a virological decline, significant decline of greater than 0.5 log copies at 10 days. And if that happened, they went on to continue on lenacapavir plus their optimized backbone, so their regimen was improved. And then the placebo arm also went on to then receive lenacapavir and the optimized backbone. And then they took everyone who didn't screen successfully into the study, and they put them into a non-randomized group and gave them lenacapavir. So here we see the results. We can see here the proportion of participants who had viral loads greater than 0.5 log decline. You can see that 88% did for lenacapavir versus 17% with the placebo. We can see that in terms of the mean change in viral load was a very high log drop, so nearly a 2 log drop, which is a very, very good drop, very potent. And you can see that there were 2 of the 72 people who did develop resistance at week 26 capsid mutations. Looking at safety, what you can see is that there were no treatment-related serious adverse events or discontinuations, and there were a few people who had drug-related injection site reactions, predominantly grade 1, but nobody out of all the people discontinued due to an injection site reaction. So this is similar to what we saw earlier in the injectable cabotegravir or pivirine program. So then we saw this announcement a few weeks ago. Gilead and Merck announced agreement to jointly develop and commercialize long-acting investigational treatment combinations of lenacapavir and islatravir. Now that's the best news that clinicians could have hoped for, because prior to this, we had islatravir with a very long half-life, potentially up to a year with an implant, but actually could be used as an injection too if it was developed with another agent. And now lenacapavir with 6 monthly half-life. So we really can see potentially a pipeline here, which is exciting. There are other drugs available for development in Russia. There was VM1500LA, which is now known as L-sulfavirine, which is an NNRTI injectable being developed, and also albiviritide, which is a fusion inhibitor being developed in China. So those are not being developed with the companies that we know, but they are being developed. GSK is also developing maturation inhibitors, the oral drug GSK254 and the injectable drug GSK937. 937 potentially might be a drug that could be partnered potentially with cabotegravir. Broadly neutralizing antibodies are also being developed. In human studies, these show antiviral activity, but in animal studies, these may suggest potential remission in monkeys, which may be a vaccinal effect. These can be mutated to sort of lipid formulations and mutations, which extend the half-life to out to 6 months, meaning that these drugs may contribute to long-acting treatment. But with bNAbs, you've got to use combination and tri-specific drugs to avoid resistance. So potentially these could be partnered with cabotegravir or lenacapavir. We're in the situation now where we have amazing treatments which can keep people alive to live a normal life expectancy, but we're in a situation where we are going across the bridge potentially between treatment and cure and moving towards things like post-vaccinal effects with potential bNAbs. We must be careful that in our trials and our trial designs, people that would have lived normal life expectancies don't fall into a hole of our experimentation. The final points I want to cover are the 3 no's around people who are excluded and underrepresented by clinical trials. And the thing I'd like to highlight to you is that in 2,850 people enrolled into the following 6 previous clinical trials, trans people were not counted. Around a third were people of color. 9% had CD4 counts less than 200. The median age was 33. And around 15% were women. So women are grossly underrepresented in clinical trials, as are people of color, particularly looking at the global epidemic. Totally excluded from these trials are pregnant women, breastfeeding women, and children. And this is a real travesty and a real problem. And I think it's vitally important that we continue to advocate for different trial designs and protecting pregnant women and breastfeeding women through research rather than from research. And this point has been picked up by the Lancet HIV in terms of long-acting or extended release antiretroviral products and the need for these drugs to be tested and evaluated in pregnant and breastfeeding women, infants, children, and adolescents. And I'm heartened to see the adolescent program that Beef Healthcare is doing in terms of children and adolescents, but it is really important that we get this other data. It's also important to say, and in a world which is already suffering from vaccine nationalism, and we're already seeing the differences, the great North-South divide and East-West divide, it's important, like it is for COVID vaccines, that we actually do get long-acting treatments, not just in rich countries, but these are something that everybody everywhere can access. And I think it's really important for us as clinicians, once again, not just to focus on our own countries and our own patients, but to adopt a more global view and see our world as a more interdependent place where the health of people in different countries affects our own. And COVID has, if it's done nothing else, has really made us see how true and how important this is. So I'm looking forward to taking questions in the question and answer session, and I hope that's been helpful to you. And please do feel free to tweet or to email me. This is my Twitter handle and my email address. And I hope you've enjoyed this and enjoy the rest of the session.